professors and colleagues. I want to thank you all for the Megan's group and the committee for inviting me to present this topic. It's different from headache and different from neurological disorders and surgery and spinal. I'm about obstructive defecation. I'm a physician. I'm not a physiotherapist. Egyptian, and I worked in Germany for about 6 years, and the biggest pelvic floor rehabilitation centers then back to my country to bring this new culture, a new rehabilitation was not present in my country. Role of pelvic floor rehabilitation in elderly. The obstructive defecation is another different type of constipation, not the organic, which improve with laxatives. I'm talking about soft stool. In spite of soft stool, the patient cannot evacuate or defecate, and there's severe difficulty. And this is which needs the rehabilitation. The incident is not well known because it's taboo. These patients suffer from overflow fecal incontinence after this, and they may suffer from another very painful and they don't like to talk about it. But in my country, I have 2 pelvic floor centers in Alexandria and Egypt. In one day, I can meet about 40 to 60 patients. And this means that it's very, very high incidence. You know what the meaning of the normal defecation? To defecate normally, we need normal puborectalis, which relax during defecation, because normally there's angle between the anal and the rectum to prevent the mechanism of fecal continence. And during defecation, there must be relaxation of this muscle. The angle will be obtuse to evacuate large amount of stool with the aid of the nerve. The nerve is very important, pudendal nerve, to help autonomic sensation, to help the motor power for pelvic floor muscles to hold the rectum, evacuate large amount of stool in a limited time without pain, without effort, and complete evacuation comfortably when pelvic floor work in an integrated manner. The pathogenesis of obstructive defecation, that there's physiological functional problem, that there's anismus, which is improper relaxation of puborectalis muscle during defecation, and with the result of with the chronic push in the toilet, especially when internal medicine think that this is a normal organic constipation. They give the patient laxative, the patient push, stays a long time in the toilet. So this will lead to another problem, secondary pudendal neuropathy, stretch on the nerve, and this leads to the third problem, perineum descent due to weakness of pelvic floor muscles. So we have complications. So the presentations is not only in the bowel. When I ask the patient, there's also problem, can be bladder due to this weakness of pelvic floor muscle. The patient suffers from constipation and from urinary incontinence, or it's cystocele, which leads to inability to evacuate the urine. Also sexual dysfunctions, and she visits a gynecologist and suffers from dyspareunia, suffers from sexual pain, or problems for men, also erectile dysfunctions, and by a urologist. And the problem is in the pelvic floor. When we treat this constipation, then these all will improve. And there is some disappointing chronic pelvic pain syndromes like proctalgia projects, and very, very depressing. These patients go to the neurologist and they receive psychiatrist, tramadol and other medications, and the problem is in the pudendal nerve. The program starts with diagnosis and assessment, and then health education, because as I told you, in my country, it's a new pelvic floor rehabilitation, the new rehabilitation, which we don't know about it, and therapeutic exercises. And when I discuss with you the modalities, which is my specialty. Diagnosis, very important history taking. I must take 1 hour with the patient to ask about the evacuation of the stool, about the habit, about the amount, the usage of water plush, which is common in our countries, about usage of laxatives, and what's important about also fecal leakage when there's or incontinence, about urinary, sexual, to manage the condition as a whole, or not only the fecal problems, the bowel disorders. And clinical examination I'll discuss now with you. I'm not a gynecologist or a urologist. It's not my specialty to assess the patient for these conditions. I can do dynamic pelvic floor MRI during defecation, and I can assess the condition as I need. But my specialty is radiotherapy to assess the process of isolation for each patient. I have to assess if the patient can perform isolated pelvic floor muscles contractions or relaxations without usage of other accessory muscles like abdominal, like hip, buttocks, and then to start these strengths, because I can't start pelvic floor rehabilitation when the strength is below 3. According to my modified Oxford, I put my fingers, there must be a lift. When there's no lift, so I can't start pelvic floor rehabilitation, so the muscles are very weak. According to the measures, there are 3 important measures I have to measure to each patient. Each patient in my clinic have important values as a folder for the baseline assessment. The maximum strength of maximum pelvic floor contractions, how the pressure, and then how long can he maintain the patient this maximum value, and flex rapid contractions, and also the pressure of straining during defecation. There are very important values. And we have also electrophysiological study, which you can do it using Sunmark electrode to measure pudendal nerve, which is very important for 2 reasons. Why I do this evaluation? I have to localize. Is the problem in the nerve or it's in the muscle? It's combined to help which type of physical modality I will use for my patient. And also it's important to know the progression, the provision for the patient. I mean, there's good prognosis when we don't have pudendal neuropathy, and this is it's not common in my country. In my country, many women have pudendal neuropathy, severe pudendal neuropathy, because they are obese, because of descent. Diabetes is also very common, so it's very common to have the pudendal neuropathy, and this make the rehabilitation is with poor to moderate prognosis and not a very good prognosis. Health education, very important with the patient the first day, because they ask me, we know about rehabilitation for the neck, for the back, but how with the pelvic floor? What will you do? What are the physical modalities? So I have discussed this with the patient. I have pictures and videos to show the pelvic floor, how it's holding the rectum, the uterus in women, also the bladder, and what's the mechanism of the normal defecation, on what do I need from the patient, and how health education for her life, for his life, for the life education. I mean, lifting heavy weights is not good. About some indications during sex to improve their life. As I said, very important eating and drinking. But as I said, it's not a normal constipation. I don't mean that when they eat healthy, they stop this problem and it will resolve. No, the problem is they're present. But when we eat bad dietary habits, so we have more and more problem. According to the, as I said, the sport and the sex, there's also very important indications. Proper toileting position is very, very important. Putting this about 45 to 35 degrees below the legs help the patient to improve evacuation, because it's the normal proper toileting position. According to exercises, Kegel exercises, we don't have, unfortunately, culture about these exercises. I was in Germany and here in London. I know that they have portable devices which women and men can use at home, but in my country they don't know about it. So we also and also we have a passive people, you know, in the Arab, they don't practice exercise. So it's a new culture when you say you have to exercise your pelvic floor muscles, because they are always think that pelvic floor exercise rehabilitation in the clinic with devices, it's enough. And I don't need to do exercises at home. And I say, no, it's like any muscle in your body. You have to train active training and not only passive training, depending on devices which we use in the clinic. According to the exercises, we have to make a program to the patient after using the physical modality. Biofeedback. Biofeedback is a very important, it is a spread of the pelvic floor rehabilitation. I have in my clinic new era of pelvic floor rehabilitation devices. I am talking about electromagnetic, about the chair, Imzala chair, which make 11,000 Kegel in half an hour. I have the super inductive system for the relaxation for hypertonic pelvic floor, but biofeedback still the most important physical modality in pelvic floor rehabilitation, because other muscles we can contract and relax, upper and lower limbs, and you can see your back, your neck, but pelvic floor muscles is the internal muscle, it's inside us, and we can't recognize if we are contracting it or relaxing it properly or not. And this is the benefit from biofeedback. It's behavioral therapy. There's a screen in front of the patient, and he hears sound, he can see a graph to detect he's doing these exercises correct or not. And when he is doing it correct or not, we can start the rehabilitation, because researchers prove that written or verbal constructions, the patient can use other accessory muscles. So this is the benefit of pelvic floor exercises using biofeedback, because incorrect pelvic floor rehabilitation or exercises at home will lead to pain, fatigue, and worsening of symptoms. So biofeedback is a very important bridge to this patient for isolation of pelvic floor muscles contractions or relaxations. The device, we have manometric and electromyographic with these probes. The types are double channel or single channel. I start with double channel when the patient cannot isolate. About 1 to 3 sessions, stay with the patient about 1 hour, and she can see 2 graphs in front of her, like for example here, and the patient with trial and error, we try to teach her, she can see 1 graph from the pelvic floor, anal, in the women and men when they are suffering from the fecal problems, and when it's urinary, so we can vaginal if she's married. And we can see another graph from the muscles which they also contract concomitant with the pelvic floor muscles. And we try and error, we motivate the patient, try to contract only pelvic floor muscles till she can, in the blue graphs, only pelvic floor muscles without the other muscles. In this stage, I can start pelvic floor rehabilitation. I want to strengthen the muscles when there's weakness, or I want to help relaxation during evacuation defecation, according to the single channel. Single channel, I put the probe in the anal, and I start with the patient to see 2 graphs in a tilting position, and I ask the patient to relax pelvic floor muscles puborectalis during straining. I mean, during straining, I can see the graph on 0. There's no pressure. So the patient, we help her with sound. When she hears the sound, she said, no, I don't know, I don't want to hear the sound. Try to relax during defecation and so on. Then we see relaxation, and this is, for example, here in a patient, after 5 sessions, here it's around 50, the pressure during defecation, and here below we can see it's below around 2 or 3 the pressure. The principles for biofeedback, it's a long time, exhausting of course. Also, it could be customized for every patient according to the values. I have problem with the endurance, I have to flex according to which type of exercise I have to do with the patient. Also, reinforcement is very important. All the patients ask, I finished or I have to repeat the sessions. Some patients need after 3 months, 6 months, and we nowadays we have portable devices. I can give it to the patient and he can use it at home. The success of biofeedback depends on compliance to the sessions and exercises at home. And very important, the compliance to the sessions is the doctor-patient relationship. And this is very, very important. This is the key to success. The patient must not be afraid to say everything and every details about me to help him to succeed and get good from this problem. Recommendations. Is it alone biofeedback? No, as I said, therapeutic exercise is important, life modifications is important, and there are another devices like anal electrical stimulations. I prefer biofeedback personal to the patient for these electrical stimulations. The nerve can be used through anal probes, personal use to the patient for the nerve, to stimulation to the sensory nerve, to be able to feel these pelvic floor muscles, or we can use an old modality, interferential. We can use it externally, and we can use it to also strengthen colonic movements, and this is very, very common. You can use it also in children in my country. And there's what's the posteriotibial neuromodulation, another modality with needles or percutaneous to the posteriotibial nerve. It's the theory that it decreases nasmus, but it's FDA approved in overactive bladder. My message today, that pelvic floor rehabilitation can open doors to this patient to improve their life. Don't leave this patient suffer in silence. And thank you.